Hi, everyone. Welcome to today's webinar about financial navigation. Thank you for bearing with us for a few minutes while we get started. We understand that a lot is going on in the world right now, and we are so glad and fortunate that you were able to take the time out of all of your busy schedules to join us today. So my name is Victoria Singer. I am the Manager of Product Development at the Patient Access Network Foundation, and I will be moderating today's webinar. Today, you'll hear from these three speakers. On the next slide, you'll see our information. First, you'll learn from Dan Sherman, the founder and president of the Navigators group, who will give an introduction to financial navigation. Next, we'll hear from Lori Schneider, Oncology Operations Manager at Green Bay Oncology, who will discuss unlocking charitable assistance. And last, we'll hear from Amy Niles, the Executive Vice President of the PAN Foundation, who will speak about the importance of advocacy. Before we begin, I would like to provide you with a few housekeeping notes. I'm sorry, I'm hearing that they're not able, is everyone able to hear me? Okay, great, okay. Sorry about that. So we will have a few housekeeping notes in the next slide. Throughout the webinar, if you do have any questions at all, please do submit them by selecting the Send Question to Staff option within the chat box, and we will answer all of your questions at the end of the webinar. We also know that we are going to be providing you with a lot of information today, so please, for your convenience and reference, do refer to the recording of the webinar, which will be made available to you on our website. We will send out an email notification when it does become available. Lastly, our contact information will be shared at the end of this presentation for any additional questions, and you can always refer to resources available on our website at panfoundation.org. Let's go ahead and get started on the next slide, where we will review the agenda. Today, I will share with you some information about the PAN Foundation, who we are, the type of support we provide, and why we decided to create a webinar series about financial navigation. Dan Sherman and Lori Schneider will dive deeper into navigation and charitable assistance, and Amy Niles will speak about advocacy. We have saved time at the end for a robust Q&A session. Let's learn more about PAN on the next slide. PAN is a nonprofit organization that is dedicated to helping federally and commercially insured patients with out-of-pocket costs for prescribed medications. Our mission is to help underinsured people with life-threatening, chronic, and rare diseases get the medications and treatments they need by assisting with out-of-pocket costs and advocating for improved access and affordability. We offer three types of financial assistance programs, which are provided in the form of grants. The first type of assistance program is medication assistance, which makes up over 90% of all of our programs and covers copays, deductibles, and coinsurance for prescribed treatment. The second type is premium assistance, which provides financial assistance for monthly insurance premiums. Lastly, we support travel assistance, which covers the cost of transportation, lodging, and other costs incurred for the patient's treatment visits. In hosting this specific webinar series, PAN seeks to provide resources to healthcare professionals and patient advocates as they implement and improve the financial navigation services offered at their facilities. We are a safety net organization which is invested in the success of navigation programs across various healthcare settings. Our goal is to support healthcare professionals with the knowledge needed to build the case for establishing and expanding their organization's navigation programs. Today, our speakers will walk you through four key areas. 1, defining financial navigation in the healthcare setting. 2, recognizing the differences between various types of health insurance coverage. 3, identifying where and how to find charitable assistance for patients. And 4, understanding the scope of resources that is available to patients. And I will now turn it over to Dan Sherman, who will provide an introduction to navigation.
Well, thank you very much, Victoria. Thank you for the invitation here to speak to all of the attendees at this webinar. For those of you who know me, you know I'm extremely passionate about this topic here of helping, especially oncology patients as they navigate the financial implications of their care. If you can move to the next slide, I can get started. So I don't want to spend a lot of time here talking about statistics because I can imagine that most attendees on this webinar here already know how toxic financial distress can be for your patient population. But I want to point out just a couple of things here. When we think about financial toxicity, financial distress in the oncology patient population, we need to understand, or it will be wise to understand, how this impacts the patient, not only from a practical standpoint in regards to the distress that they're feeling, but also in regards to outcomes for the treatments that they're receiving for their oncology diagnosis. So we know in regards to treatment adherence, how financial toxicity impacts that. On average, is in the mid to upper 20% of your patient population is going to be struggling with treatment adherence secondary to the cost of the care that they're receiving. And then we also know that the higher the financial distress that the patient is experiencing, the more distress, emotional distress that that person is experiencing as well. And there's research now that is starting to show and demonstrate that the higher stress the patient is experiencing, the poorer outcomes they're having in regards to their oncology care. And so not only is this important from the standpoint, from a humanitarian standpoint, right, helping people with distress, but it also has an impact on outcomes. One quick more thing here on this topic here. There was a study done back in 2016 that took a look at asking the question, do you want to talk to somebody about your financial obligation for your oncology care? And there was one study that found that 94% of the patient population wanted to talk to somebody about the financial obligation, and only 14% of them ended up having a conversation with somebody within the healthcare setting. So it's a huge unmet need that we need to be paying attention to. Next slide, please. So the question that comes up here is, how are we addressing this in the healthcare setting? And as I've traveled the nation and assisted oncology providers with implementing financial navigation services, there is this trend that I see that there's three general approaches to addressing this problem. Now, I don't want you to get fixed up on the titles of these roles. What's more important is the function of the roles and the responsibilities that these roles have. I've categorized them this way, but that does not mean, once again, that you have to do it this way. But generally speaking, across the United States, hospital systems have individuals in the role to address the financial concerns of patients. In some of those institutions, the individuals that are functioning in this role are assisting people with enrolling into Medicaid, and they're assisting them enrolling into the charity program that the hospital might have, generally speaking. Well, we know in the oncology setting that if we only take that approach, we're going to be missing a lot of patients in regards to the financial distress. Approximately 20% of the population qualifies for Medicaid. So what are we doing with the remaining 80%? And probably the numbers are fairly similar in regards to charity programs, hospital charity programs, that 20 to 30% of the population might qualify for it. And what are we doing with the remaining? So if we move up to the next level, that I define as financial advocates, the financial advocacy model takes a look at enrolling people into a lot of assistance programs that are out there. We can move back one slide. That would be great. Enrolling people into copay assistance programs and patient assistance programs, basic needs programs, like organizations like PAN, these are fantastic organizations. And we know that oncology patients are receiving many more services than just products from pharmacy, right? So chemotherapy and oral medications, but patients are also receiving radiation treatments. They're having their PET scan, they're being admitted to the hospital. all of these other services, the copay assistance programs and the patient assistance programs doesn't address that issue. And so what are we doing to paying attention to these needs? All of the statistics that we're looking at here in regards to financial distress are taking place when these copay assistance and patient assistance programs are available. So financial navigation attempts to look at the patient from a whole and looking at their diagnosis in the context of the insurance coverage that they have. It takes a look at, can we move a patient from being underinsured with their insurance policy to being more fully insured, so that when they come in for their radiation treatments, or when they're coming in through the emergency room or being hospitalized for their surgery, that the coverage that they have is meeting the needs that they have for that specific diagnosis. So financial navigation is treating the problem by navigating our complex healthcare system that we have. Can we move to the next slide? So real quick, I'm not going to spend a lot of time on this because I want to show you some practical examples of this, but financial navigation is treating financial toxicity by proactively guiding patients through our complex healthcare system to help them gain access to care by reducing financial barriers. The key issue here is being proactive in your approach. Let me give you a quick example of what this means. So if a patient comes in for surgery and is not laying on the operating table, and the surgeon walks in and starts doing the procedure, the surgical procedure, cuts the patient open, does what he or she needs to do, sews the patient back up again, and the surgeon leaves the room, and the very next person that walks into the room is the anesthesiologist saying, I'm ready to give anesthesia now, right? We have greatly harmed our patient if we take that approach. But in many healthcare settings across the United States, that's the very approach that we take when it comes to financial toxicity. We treat the patient and then we send in the financial advocate or we send in the social worker, say, can you fix this problem of this big bill they have? And many times it's too late to do so. Financial navigation takes a look at, can we address this issue proactively, fix the insurance if we can, then use all of the financial advocacy programs that are out there, the copay assistance and patient assistance programs and basic needs programs as well. So I've used this acronym here, the acronym TREAT, to try to explain what financial navigation is. So it starts with, first of all, having a team, right? It is critical that the financial navigator is integrated into the multidisciplinary team and they understand the dynamics that is going on with this patient from a treatment standpoint, from a side effect standpoint, how long is this patient going to be in treatment? And then it requires a level of expertise as well. So if we can move to the next slide. This level of expertise is critical in order to be able to navigate patients through our complicated system, right? So down on the bottom right-hand corner here, I talk about that it's important to have some level of disease knowledge and the treatment process so that when you're working with the patient from an insurance standpoint, that we're being cognizant of the fact of what treatments are they needing. I'm going to give you a practical example of this here in just a minute. But then you combine that knowledge with also having knowledge of our extremely complicated healthcare system that we have. So understanding Medicare and Medicaid and COBRA and Medicare Part D and the Medicare Savings Program and the Low Income Subsidy Program, how do all of these different systems come into play for your patient? Once you've done that, then having expertise in all of the external assistance programs out there, including the PAN Foundation, is critical to be able to make this system work well. We can move to the next slide. So let me just give you a practical example of this. Here's a 67-year-old married male diagnosed with metastatic melanoma. So monthly gross income is $1,680 a month, and they have $11,000 in assets. He has Medicare A and B only. He is not enrolled in D. So he has no prescription coverage and he has no secondary coverage as well. And it's June of, well, here's 2020, you can say June of 2021. And he needs surgery followed by biologic therapy. So when we took a look at the full cost of treatment for 1 year, it was going to be about $380,000. When you have Medicare A and B only, there's a 20%, unlimited 20% responsibility. So he's going to be responsible for $44,000. When you look at his income and assets, we know already that he is not able to afford this. So what can we do? Well, the typical hospital intervention that has occurred throughout the last decade is to see, well, maybe we can get this gentleman free drug. That will take care of this problem. And I agree, that would help a lot. It would put a big Band-Aid on the sore. But what about all of his other medical services that he needs, right? The surgery, the emergency room visit, the PET scan, those are all going to generate bills for the patient. So if we can move to the next slide. The financial navigation intervention takes a look at, well, can we educate this patient on his insurance options? Well, it's June, right? So it's not open enrollment for Medicare, but because of his income and his assets, he qualifies for something called low-income subsidy. Low-income subsidy fixes Medicare Part D. It doesn't fix his medical component, but it fixes his prescription issues. But if you qualify for low-income subsidy, now you can enroll into a Medicare Advantage plan, or in some states, you can actually enroll into a Medicare supplemental policy. That would be better for him. Why would this gentleman want to enroll into a Medicare Advantage plan? Well, with Medicare Advantage plan, you have something called a max out-of-pocket. I just read a report yesterday, the average out-of-pocket responsibility that a Medicare Advantage plan has is right around $4,500. And I would argue that a $4,500 responsibility is better than a $44,000 responsibility. Now that he's enrolled into a Medicare Advantage plan with a $4,500 max out of pocket, now we go after the copay assistance programs that could help with some of his biologic therapies and his co-insurance responsibility there. But we know that when you are receiving biologic therapies, usually within the second treatment that you've received, you've reached your $4,500 max out of pocket. Now he's at 100% coverage for the rest of the year. And his emergency room visit, his hospitalization, his PET scans are being covered in full. We can move to the next slide. Let me give you another practical example here. Here's a patient who is in the Affordable Care Act. Taking a proactive approach here is this critical. So here's an example of a patient that came in. She's 45 years old with 2 minor children making $58,000 a year. She's diagnosed with ovarian cancer and needs surgery followed by 6 months of chemotherapy. It's currently April of 2021. Now, usually it's not open enrollment for the ACA. Now, it happened we are in a special open enrollment right now because of President Biden's stimulus package that he passed. But normally there would not be open enrollment right here. She has a significant decrease of income coming her way. She only has 3 months of short-term disability payments available to her, and then she has no other disability payments available to her. So her income is going to move from $58,000 a year down to right around in the high 30s, right? That's a significant decrease of income. And when you move from not qualifying for subsidies in the ACA to qualifying for subsidies in the ACA, that generates a special open enrollment period to notify the marketplace of your decrease of income, and you can actually change your plan. So if we move to the next slide here, I'm going to show you what happened in this case here. Here's the patient's current insurance. She's paying $653 a month for that policy. But she has a $6,800 deductible and a $17,100 family out-of-pocket responsibility for her care. Can we imagine a single lady with 2 children with a significant decrease of income coming into the home and is faced with this? I wonder what that's like and the stress that she's feeling. On the day of consult, if we move to the next slide, we called the marketplace together, and this is what happened to her policy. Her premiums went down to $149 a month, and her out-of-pocket went down to $2,500. Because of that significant decrease of income, her 2 children went into Medicaid, and then she now ended up with having a $2,500 out-of-pocket responsibilities. Now, once again, we can utilize the different foundations that are out there to be assistance for her, maybe some basic needs programs that could help with her mortgage or rent if she has that. But once again, what I'm trying to explain here is the importance of the idea behind financial navigation is to have somebody have a financial navigator that understands at a deep level our very complicated healthcare system. And when patients are coming to us, we proactively start addressing these and educate our patients on what is available to them. I am not proposing that we tell a patient what insurance to sign up for. I am advocating that we educate our patients on what is available for them to significantly decrease their out-of-pocket responsibilities. If you can move to the next slide. So once again, once we've done the insurance optimization, now we change our focus of looking at all of the different external assistance programs that are out there. So the free drug programs, if that's necessary, the copay assistance programs, the premium assistance programs that Victoria just mentioned earlier as well. You know, this person might qualify for a premium assistance program, and even the $149 that she's now paying for her policy could also be covered, moving her to having that policy for free. And let me just point out one more thing here in regards to this example that I just gave you. If no intervention was done, right? If we just took a reactive approach to that person, the single female with 2 children, if we just took a reactive approach to this and maybe enrolled her into copay assistance, I would argue that her health insurance would be at risk. Would she be able to afford the $600 a month premium? Would she be one of the statistics of saying, I'm not going to do care, I cannot afford this, I can't put my family through all of this? That is what we're trying to prevent here. So the focus, once again, insurance optimization, help people move through our complicated healthcare system, and then move on to optimizing all of the external assistance programs. I love the title of this presentation here. The title is An Introduction to Financial Navigation. Financial navigation is extremely complicated. It takes a fairly high level of expertise of being able to do stuff with this. So this is just getting your feet wet and understanding all of the different opportunities that are available for our patient population. So I think I can move it now to Lori, who's going to discuss more the external assistance programs.
Okay, there, now I was unmuted. Thank you. So as I was saying, thank you, Dan, that was very helpful, all that information. It doesn't matter how many times you see that presentation. Dan has some really helpful guidance, and I want to reiterate, with this being an introduction to financial navigation, somebody is not going to walk in the door and be able to manage doing this and knowing all of these facts right from the very beginning. So I'm going to touch on charitable assistance. What is it? Why do we need it? Where do we find it? And when do we use it? It was exciting to talk with the PAN team about this and get to learn a little bit more myself, and I'll explain that in the upcoming slides. So next slide. What is charitable assistance? In our world as we're looking at it right now, this is more of our national foundation assistance, not as much of the smaller local foundations that you have. So they're nonprofit organizations that help to provide various forms of help to our underinsured patients, and that's a key, is to our underinsured patients. These assistance programs are regulated by Health and Human Services. I promise you, they cannot just go in and make up whatever rules they want whenever they want. even though sometimes on our end in the clinic side, we're like, what are they doing and why can't we get this? It really is. There's a reason behind what they're doing. Each foundation has an advisory that describes how they must operate as well. And the goal is to cover patients' treatments whenever possible, so that way we don't have to have 2 or 3 funds available in different disease states, even though that's what we are doing in order to help patients. So next slide. Understanding our charitable assistance, funding availability. So why does it come? Sometimes why is there a lot? Why are there times where we feel like there's none? Why does it appear that there's some right now, but in 2 minutes it's gone? It's all about the dollars available and the number of patients that are approved. How many donations is that foundation getting in? Even though a donator cannot tell a fund like what medication it's for, that fund all depends on the dollars that come in. How many people could be on the wait list? How many unused awards are there? So a patient could be awarded $10,000, but only used $5,000. Their year is up or less, or they don't need any more funding. So that money can go back into that pot. But how, it all depends on that constant turnaround in patient demand. And then each foundation, I really want to reiterate this, so I did put it on this slide as well, that all of these are governed by an advisory opinion, and the foundation really has to go ahead and talk with them to make their decisions. How do they want to go ahead and do this? What makes the most sense to make sure that they're following the rules? We know a few years ago there was big talk out there about what foundations could Medicare have foundation assistance. So that is something that is always being discussed. Okay, next slide. The funding guidelines, they are awarded on the first come, first served basis. Those donations, like I said earlier, are by disease state, and they assist federally and commercially insured patients. And I can tell you this team at PAN, when they first started talking to Dan and I about this webinar, they probably didn't expect that Dan and I were going to start firing all kinds of questions to them, and they were essentially being interviewed for us to help understand, because I think on behalf of everyone out there in the clinics, we were struggling to understand it as well. And even though we hear, it's awarded on a first come, first served basis, it was really reassuring that this team is working so hard to ensure that the patients get everything that they need up front. And this team also really wants to know what we're looking for and how can we further help patients, or what's further needed. So thank you to that PAN team. Okay, next slide. Financial toxicity. So I want to touch just a tad bit on what Dan talked about. Being proactive. I truly believe you need to be proactive in this role. To be reactive, Dan said it very well, that's putting your anesthesia before the surgery. Those high premiums, look at what that patient in the case study had for high premiums. Even in the one slide in the beginning, Dan had that the average premium, I believe in 2020, for a family was $21,000. That is through the roof. We wonder why we have financial toxicity, and that's not even with the patient getting their treatment or having been walked in our door at this point to be told what they're going to have to go through. Poor insurance coverage, the underinsured. Quite honestly, when I look back for financial navigation, I started this team about 15 years ago now. Back then, we honestly had deductibles of $100 or $200 and out-of-pocket maximums. Man, if we saw out-of-pocket maximum of $1,000, that was rare. And now we're looking at out-of-pocket maximums of $10,000 or more, $15,000. So how do we go ahead and try to manage that when we all know our incomes didn't increase by $15,000 or $20,000 or more in the last 10 years? So that's just another way that when you look at it, it helps to start putting that financial toxicity in perspective for what the patient is going through. The increased time away from work, obviously more appointments. Patients are coming more often, more things are needed. Even now, with all the authorizations out there, again, years ago, we didn't need authorizations. Now everything needs an authorization. So a patient can't just come and have something done right away. They have to come, we have to schedule something out, we have to make sure an authorization's in place before they turn around and walk back in the door. So all that extra time also creates more financial toxicity because it's more time away from work. Increased child care for all those appointments. Travel, we know the PAN has travel assistance as well. Travel has really increased in need in the past probably 5 years. I would think a little over 5 years ago, we didn't hear as much as it being an issue for patients for needing assistance. But now I can tell you we have social workers that sometimes I think those poor social workers spend more time finding travel assistance for patients, even just setting up actual transportation, not just the reimbursement for it and assistance. So that has definitely increased as well. And then the delay in those doctor visits. We know, one instance is COVID. We've delayed our screenings. So now we've delayed our screenings. Could that potentially lead to a patient first coming to our door with more widespread disease? Sometimes just the cost to go to the doctor. If we know we have to make that copay and we just don't have the money, we're going to put off, maybe my symptoms aren't that bad, maybe that cough isn't as bad, or maybe that ache or pain isn't so bad. Well, you can put that off and put that off, but all of a sudden at some point you have to go in, and that could be leading to more widespread disease as well. Okay, next slide. So to list out some of the charitable foundations, many of you on this webinar are very, very well informed about them, but I thought it was helpful to go ahead and have that list in front of us. And because the slides will be shared, you'll always have this list. So the Patient Access Network Foundation, the Assistance Fund, Cancer Care, Good Days, like I said, these, Healthwell, LLS, NORD, PAF, and Patient Services Inc. They help with more than just cancer. They can help with a lot of side effects. They can help with other disease states. Don't be afraid to do your research and look into each of these foundations. And if you're finding something you're not sure about, try to get a connection or send a message to the foundation to see, is there anything that maybe you're just not considering what the actual funding could be under? Because sometimes you don't think, maybe it's ARNS or something, and maybe it's not under a separate fund and it's under one that you're actually not looking at. But there's a lot of opportunity to reach out to these foundations and try to get that assistance that you need. Okay, next slide. So some examples of assistance. I actually spent a little time Googling to just see like how many different ideas could I come up with. And honestly, there's a lot more than this that I didn't even list. But we know, the traditional copays, insurance premiums, help with medications, those are all available, but there are a lot of other available resources out there that can help with other things. So the meals, like Meals on Wheels, can help. There's help with lodging, utilities. Reach out to your local utility company. A lot of times they have their own resources to help with patients, or anybody in the community who just doesn't have the resources to help pay. There's legal assistance, housing costs, and it could be not only on the national foundation level, but on your local foundation as well, that some of these are available. I know one of our local foundations has help for everything. We've gotten help for water bills, for rent, to help make a mortgage payment. There is a lot of help if you just don't be afraid. All you can do is be that advocate and go in and just help question things and raise awareness as well. Another example I have is we have a local group that does a motorcycle ride every year. And the gentleman that runs it formerly worked with the Green Bay Packers, and he wanted to be able to help patients and was wondering where there was need for help for our cancer patients. And we told him that some of our patients really need help with their oral medication costs that just aren't covered by foundations or by pharma. So he helped to create a fund specifically for patients who need help with oral medications. That's not pain medications. These are oral medications to treat that oncology diagnosis. And that has been huge. We have helped, I would bet, upwards of 50 or more patients a year for the past few years, just by raising that awareness and being that voice for patients. So next slide. So this is a very high level medication assistance decision tree. I didn't want to go into a lot of detail with this because a lot of it Dan had talked about how to manage the upfront process. But if you have a patient that comes in the door and needs IV or oral, in this case, we'll put them both into the same basket right now. Review their insurance coverage. You want to make sure that, one, are they covered? Are they okay to even walk in the door to get treatment in your facility? We have a benefits specialist who reviews every patient's insurance to make sure we're in network. We double check what their out-of-pockets are. We're making sure that if there's any concerns up front before the patient is even here, that we're sending a red flag to our financial counseling team to be like, hey, you're going to want to meet with this patient. They probably are going to need a little extra help, or maybe they won't. We don't know that, but at least the patient knows we're a resource there for them. In return, our financial counselors then meet with all the patients and provide them that summary of what their benefits are, explain what their out-of-pockets are going to be, so that way the patient knows exactly what to expect going into their appointments and where they have help. Every single benefit sheet for a patient has the financial counselor's business card on it with their direct line. So there's always somebody there to help these patients. After we review the insurance coverage, you're looking, like Dan had stated, does the patient need LIS? Do they have the appropriate coverage? Are we getting close to open enrollment that we need to consider something different? Could they potentially be Medicaid eligible? Or other resources. In Wisconsin, we have a pharmacy plan for seniors over the age of 65 called Senior Care. It's only for Wisconsin residents, but it's something that a patient can get enrolled in even outside of open enrollment. And then you're looking at commercial or insurance or Medicare insurance. Where do they fall? What does that patient have to help determine your next set of steps that you want to take? So if a commercial patient, you want to go to that copay card or foundation for help. And if it's a Medicare patient, you want to go to the foundation. In IV world, after that, if there's still out-of-pocket costs that we cannot manage to find enough help for and the patient can't afford, unfortunately, at that point, we go to charity care. But that is our very last resort ever. We don't promote that by any means. It's all about finding that help and making sure we're getting what the patient needs up front, because realistically, it's just not the medications from us. It's just not the medical care from us. It's what that patient's experiencing throughout all of their appointments. And the process is pretty much the same for the oral medications, with the exception of we lean heavily on pharma assistance for the oral medications whenever we can. Okay, next slide. So since I work with ACCC and I am the chairperson for the Financial Advocacy Network, I thought it was only fair that I put a little plug in here about all of the resources that are available through the ACCC. All of these resources can be found on their website or by reaching out to them. You can be directed or find somebody that you can contact within this committee as well. So we have not only a network advisory committee, we have the overall network has the advisory committee, and then we have subcommittees underneath. And I think it's important to know that if you are passionate, you can help get involved in areas. Right now, our subcommittees include topics and work on things like for networking, for staff education. We're putting together a lot of information to help staff with training, and then policy for those people who are brave and love fighting policies. So there's few different subcommittees. We have advocacy service guidelines. We have 2 different levels of the boot camp right now, and there's a few of those that are under revamp to keep them current, so that way we're giving the most up-to-date information. The advocacy toolkit has had a revamp already. The patient assistance and reimbursement guide will be a good go-to for you that helps tell you where there is help for medications. That one is updated quarterly or more frequently if time allows, but we do have a team that sends information. As soon as we see it, we have a core group that we make sure that's getting updated. And then the ACCC exchange, where you can go on and send questions out to the community across the United States. Hey, I'm having trouble with this. Where are we at right now? Can anybody give me guidance? So that is some of the ACCC resources that are out there. Next slide. So additional resources, and I feel it's really important to highlight these as well. The American Cancer Society has a lot of resources for our patients. They can be a support in many different ways that internally in a clinic we probably just don't touch on, but they are there for that patient and their family. Some search engines out there, Aunt Bertha and the Cancer Financial Assistance Coalition, they are great. You can put your zip code in, you can put what you need to help that patient. So is it help with housing? Is it help with meals? Is it help with, there's so many different topics underneath these search engines that you can go ahead, it will sort it out and tell you what's available within the patient's zip code to help them. So I highly recommend reaching out and utilizing those tools as well. Our local foundations, I touched on that a little bit. There are many probably local foundations that are underutilized that you just don't realize. So make Google your best friend and be that advocate. Get out there. LinkedIn is another great resource for a lot of these foundations. You can find a lot of resources if you start connecting with people in the financial navigation community. They will constantly bring things forward and like, ooh, I want to see if that one works in my area too. So don't be afraid to use your resources and use that networking. The National Association of Medical Access and Patient Advocacy is a newer group. They have put together some great resources as well, and I believe they have a conference coming up in the fall as well. Needymeds.org. I think, honestly, when I look back, this is what got me through financial navigation and developing my program is years ago, only Needymeds, probably Needymeds was the only one that existed out there at the time to help me. So that lists out the medications by brand or generic name, and then along with all of their other resources that they have available right now. And pharmaceutical company websites and your reps. Use your reps. Those reps will listen to you. They understand what you need. We have been successful in helping pharma companies understand what's difficult for patients. So if a pharma company comes to us and says what's working well and what's not working well, we tell them from our perspective and the patient perspective, and we've seen changes. So make sure you're utilizing them to get those additional resources if, depending where that fits in your path for taking care of that patient. Okay, next slide. So in our organization, now this is trackable foundation money. After we've done all of, helping to figure out where we can find other resources for the patient and we have to do foundation, we were able to capture last year almost $7 million. Now I cannot track money that's come from all the foundations or for all the medications we've given because some of it is manual and I just can't get that information, but we're looking at $7 million that we've brought in between our organization to the healthcare organization and the patients. And that's huge. That's how we're out there fighting financial toxicity and helping to navigate this crazy financial world for these patients. And next slide. I think, Amy, you're up. We'll turn it over to Amy now.
Can you hear me now? Okay. Thanks so much, Lori. And Dan and Lori, thanks for participating in the webinar today. On behalf of the PAN Foundation, I want to express my appreciation to all of you who are participating in the webinar today. And importantly, thank you for all you do on behalf of patients. Every single day at PAN, we hear from patients, we hear from providers, pharmacy staff, patient advocates about the impact that financial assistance has on helping patients begin and adhere to treatment. We hear how this financial assistance helps improve the lives of so many patients. So helping patients navigate to needed resources is critically important. While PAN is 100% committed to providing assistance to cover out-of-pocket costs for prescription medications and treatment, At the end of the day, we wish that patients simply did not have such high out-of-pocket costs. It is simply not affordable. That is why, in addition to the copay assistance programs that we operate at PAN today, that's why in addition to the programs we're developing to help address the needs of patients more holistically, we are strongly advocating to reduce out-of-pocket costs for Americans. What does this mean? It means that we're advocating for things like a Part D cap on Medicare. So there's a limit to what patients are paying out of pocket over a 12-month period. It means that we're advocating for something called smoothing, which means that in January, patients are not going to be faced with hundreds or even thousands of dollars in that 1 month alone. It means that we're advocating to expand and enhance the low-income subsidy program for vision, dental, and hearing benefits in the Medicare program, for no copays for existing and future vaccines in the Part D program. All of these are so important. And so we're spending at PAN a lot of time educating members of Congress and their staff about the enormous challenges that patients are facing every single day accessing and affording the treatment that they need. And we're spending a lot of time encouraging individuals to send their voices to the Hill. We want members of Congress to hear from their constituencies. And so it's really important that individuals can share their stories. So I trust that many of you on the webinar today share our advocacy agenda at PAN. Elevating your voices as organizations, as patient advocates, even as individuals whom yourselves you may be experiencing high out-of-pocket costs for treatment is really important. So you each have so much to contribute to this dialogue, and I would encourage all of you to get involved in advocacy. I'm here to talk to any of you to help you sort through the many ways that you can get yourselves involved at the federal or state level. My email is aniles@panfoundation.org. I know it'll be shared at the end of the presentation as well. But thank you again for joining and all that you do on behalf of patients every single day. And with that, I'll turn it back over to Victoria for Q&A.
Great. Thanks, everyone. That was such a great conversation that we just had. I think we even see it in the chat box. We've been seeing so many really detailed and thoughtful questions, and I think we'll just jump right into it. So first, I'd like to ask Lori and Dan, how do you engage with a patient when they are initially referred, and how do you navigate them through the system, and how do you do follow-ups with them?
I think from our standpoint, I touched a little bit on that earlier, how we meet with the patient right from the very beginning when they first walk in the door. If there honestly is a patient who has Medicare only or is uninsured, we're probably calling them before they even get in the door. But we're right there with them hand in hand as they go through their journey. My team does all of the authorizations for the patient as well as manage the financial navigation. So they are that key person to help them understand, you know, we're going to get it authorized. We don't want the patient to have to do any extra work if they don't have to. It's one team that goes ahead and makes sure and follows that patient through that whole continuum of care. And ideally, it's one person who manages just that patient. If we need to, we have a whole team to back that person up, though. So that patient is, we do regular check-ins with that patient. If a treatment changes, we go ahead and talk with them again and explain where we are again. But it's constant follow-up, and the patient always knows we're here for some reason, and when we're they want to talk to us when we're not following up.
So I would 100% agree with Lori on how she described that. The critical issue here is seeing these patients proactively. But then depending upon the intervention that you do, if it's insurance optimization and you can actually move this patient, I mean, in many circumstances, you can move them to full coverage, then your work as it relates to access to care is finished, right? And so you don't have to keep tracking and following up. If your interventions are the external assistance programs, like copay assistance programs, you know, then having some type of a system if that's a spreadsheet or if you're using professional software to be tracking these patients and notifying you, hey, this grant has expired, and then start looking for new grants out there for your patients. And so, once again, I think it depends on the approach or what technique you've used for the patient. Now, in many circumstances, you're using both. You're doing insurance optimization and you're combining that with the external assistance programs. But the key issue here is you should be seeing a lot of your patients without them even asking you to see them, because you know financial toxicity is coming their way.
Great, thank you guys. I know Lori touched a little bit about this, so maybe we can start to hear from Lori. One of our participants says, I'm comfortable with looking into foundations for grants, but I struggle when there is no funding available. Can you share other sources?
Ouch. That is where I think every one of my team members wants to run in the other direction. Because there's nothing worse than having to go to a patient and say, I'm sorry, there's just no other help out there. But we do honestly research, our local foundations as well. What can we do internally to try to help? We have conversations with the provider and the patient to determine, is this the best medication and treatment for the patient that the patient is comfortable with as well. So a little bit of that shared decision making and being just open and honest with the providers. That's really our go-to. We get, if there isn't funding available, but we can get on a wait list, we're on a wait list. I can tell you when that little alert goes off that there's a fund that's open. It's a mad dash like you would not believe, and all hands are on deck to try to get into that funding. But for those that there's really nothing, we do have that hospital fund that we worked with that person from the Green Bay Packers with that helps a little bit if it's oral. But creativity is the key.
Yeah, I would also add, just you mentioned about when funding opens, you just hop on it right away. And I wanted to add a really important resource that we at PAN actually developed called Fund Finder, which accumulates information across all of the 9 foundations that Lori spoke about and shares instant notifications to subscribers regarding the open and closed and waitlist status of different funds. And it's not solely a PAN resource. It is truly open to all providers and pharmacies to provide information instantly regarding any fund availability, because we do understand that this is such an important resource and so valuable to so many different patients.
And I would like to point out here in regards to being put on waiting lists that does make the process a little bit easier. You don't, when you're on the waiting list, you have a couple of days to submit the application or request the funds. The other thing that should be pointed out too is that some of the foundations go retroactive back, right? So some of them are 60 days, some of them 90 days, some of them 180 days. And so having a system in place that, hey, this patient needs this treatment and there's no copay assistance available, but the financial navigator has them on their spreadsheet or their list and can capture sometimes retroactively these large copays that they're struggling with.
I think the key to that too, Dan, is having all of that information readily available from the patient.
Right.
You don't want to have to try to contact a patient once the fund opens. You want to have that information readily available to just jump into it.
Yep. Yeah, we have a worksheet here that all of the information is ready to go. The patient is giving us authorization to enroll. I agree 100%. You don't want to be on the phone calling a patient when there's 20 minutes to enroll.
So that actually leads us to the next question, which we've seen come up a little bit in the chat from other people. So I'll raise it now. It's about the ratio of staff in the clinic compared to the number of patients that you serve. So one of the questions is, for example, how many patients do you have in your clinic versus how many advocates do you have? And another one is, what's a reasonable number of advocates for a clinic with 8 oncologists?
So I think that answer will depend upon what approach you're taking in regards to financial advocacy and financial navigation. If the main focus is enrolling into external assistance programs, I think the number will be different if you're also spending the time of doing financial navigation and insurance optimization. Lori, I'm really interested in hearing your thoughts on this, but from a financial navigation standpoint, I tend to recommend that you have one FTE, financial navigator, for approximately every 1,000 new oncology patients coming through your system per year. Now, that financial navigator is not going to need to see the entire 1,000 patients, right? I mean, if they have Medicaid, they have full coverage, and they don't need financial navigation from an access to care standpoint. They might have other, financial distress, but not access to care. So typically, I find that the financial navigator is probably going to see 300 to 400 of those 1,000 patients that are coming through the system and provide some level of financial navigation services for them.
Yeah, and I think too, it's part of not only what they're doing for the financial navigation side, is there other duties as well. So in our case where we do the authorizations, and we're not only doing the authorizations, then we're helping with that peer-to-peer, and we're also following through to help with appeals. Our clinic has, I don't even know, we have 4 medical oncology clinics and 4 radiation oncology clinics right now that we have provide services for, along with a peds-onc clinic, a surg-onc clinic, and a gyn-onc clinic. And I have a total of 7 financial navigators and a benefit specialist. So total number of providers, I don't even know how many providers I have right now because it's constantly changing, I feel like, but I would say we probably have about 15 physicians and probably about 10 nurse practitioners. So again, it's spread out across not only our the medical and radiation oncologies are one health system, but then all the other specialty, the gyn-onc, the surg-onc, and the peds-onc, they are clinic-based, so it's a different facility, and it all gets a little messy, but that's about how many we have. I don't have the total number of patients because I can't even get the data from the other oncology clinics that are out there. So this is a very good non-answer probably, but at least it gives a little bit.
Yes, I think it gives good guidelines as well for people who are just trying to build this out, this capability. I do know that we are approaching time, and I want to just get Lori and Dan's final concluding thoughts, and we will be addressing these questions after this webinar as well. So please do keep sending them in and message us directly. And after the concluding thoughts, I'll just share one more slide.
So closing thoughts. Okay, yeah. I'll go first. Okay, I first of all want to commend Pan for having this webinar, and for all of the attendees out there. This is an outstanding representation of this role and this need. Knowing we had 500 people or over 500 people register for this, you guys, that is amazing. And we know everyone is craving more information. We want this role to be easier. We want the process to be easier. Honestly, knowing that where we've come from in the financial counseling or financial navigation need with financial toxicity, it really scares me. I don't see this getting easier. I don't see patients ever not needing this. I can only see it expanding and needing to be more. As we talk oncology, there's a lot of help that's needed in other disease states as well, but all we can do is keep doing what we're doing right now, uniting, working together, networking, supporting each other, and helping to educate everybody.
Thank you, Lori. I agree 100% here. A few final thoughts from my perspective is starting to comprehend, as Lori, as you just mentioned, that financial navigation is complex. And it requires ongoing education, ongoing training. And as if you're thinking about putting together a financial navigation program, look for staff for the role who are passionate about learning. I've been doing this role now for almost 15 years, and there is still opportunity to learn. The role, there's endless opportunity, in my opinion, to help people, and there's endless opportunities to learning new techniques and interventions to significantly lower the distress. Now, PAN, their advocacy of going to Congress and fighting for better coverage and lower out-of-pockets is just as critical as well. But in the meantime, our patients are suffering, and it needs, the system needs people like Lori that is out there fighting to lower the out-of-pocket responsibilities for patients.
Amy, if you have anything you'd like to add as well.
I agree with you, Dan. I think advocating on the Hill is really important, but things move just a little slowly on the Hill. So in the meantime, I think all of us need to do all we can to help our patients navigate to needed resources. Thank you again.
Thank you, everyone. So then I'll just want to share on the next slide a little teaser for what's coming soon. This is the first of a 4-part webinar series that we have launched on financial navigation, and we are very excited to take a lot of the feedback and questions and ideas that were raised today and in our own conversations internally and share the next webinar with you in September, which will be focused on the ways providers and patient advocates can actually maximize patient assistance. So please do stay tuned for more information on this exciting next event. And our last slide that we've mentioned is our contact information. And again, this deck will be disseminated to you. So please do feel free, as always, to reach out to any one of us who you heard today. We're so happy to have you join us, and we think this is such an important topic, and it was such a great use of our time, and we hope you feel the same way as well. And once again, thank you, and have a wonderful rest of your day.